Hello and welcome to today's session. Today we are going to look at chest tube drainage system monitoring and care. So we shall be looking at chest tube management. And this simply involves the act of monitoring the chest tube and the drainage system, ensuring that the tube is secure while addressing any issue that can arise while the patient is on the chest tube. And if you are to look at the definition of a chest tube, this refers to tubes or a tube that is normally inserted into the pleural space to remove air, fluid, or the fluid or the blood from the pleural space. And when you remove such, this act normally helps to re-expand the lungs. So the main objective is just to restore the normal lung expansion and also achieve the negative pressure within the pleural space, which normally enables a seamless process of breathing in and breathing out. We also have a tube that can be inserted in the mediastinum space, and this one is normally placed under the sternum, that is the breastbone, to drain fluid around the heart after cardiac surgery. So this one can also be counted as one of the chest tube. The process of chest tube insertion normally helps remove secretions around the heart, and that can if these secretions are left around the heart, they can restrict the pumping action of the cardiac organ, and this can result in an emergency, the cardiac tamponade. So we have several reasons or indications why we carry out this procedure of the chest tube. Number one is pneumothorax, and pneumothorax is simply accumulation of air in the pleural space that is going to cause lung collapse. And it could be due to a number of reasons, like the traumatic pneumothorax, which is caused by penetrating injuries like gunshot wounds, or spontaneous pneumothorax, which is common in tall, thin individuals. It could be secondary to an underlying lung disease like the chronic pulmonary disease. Tension pneumothorax is a life-threatening condition where the air enters but cannot escape, and this normally leads to increased intrathoracic pressure. So the goal of chest tube in pneumothorax is to remove the air and allow the lung to re-expand. The second indication is the pneumothorax, which is the accumulation of blood in the pleural space, and it's often due to trauma, surgery, or ruptured blood vessels. Chest tube in pneumothorax aim is just to drain the blood to prevent compression of the lung and still restore normal breathing, just as we indicated in our introduction. The third indication is pleural effusion. This is excessive fluid in the pleural space, which might be result from a number of conditions like heart failure, infections, also emphysema, malignancy, liver and kidney disease causing transductive effusion. The goal of chest tube insertion here is to drain the fluid from the pleural space, and this will help relieve symptoms like difficulty in breathing and chest discomfort. Empyema is the other indication, and empyema is actually it's just defined as pus in the pleural space, and this pus could be due to some bacterial infections like pneumonia, lung abscess, and tuberculosis. So the goal here is to drain infected material to reduce infection and inflammation and eventually promote healing. We also have other functions like postoperative thoracic surgery, like the one that we normally insert a mediastinum, a tube in the mediastinum and placed under the breastbone. I think that's the example that you have used in the introduction. And remember, when you're in post-operative surgery, The goal is to remove air, blood, or serous fluid that may accumulate post-surgery and prevent complications like tension pneumothorax or effusions. So we have two types of chest tube drainage system. We have the wet and the dry. The wet and the dry. Remember, the wet suction is normally regulated by the height of water in the suction control chamber when connected to the wall suction. So when you're having this type of chest tube, you need to observe for gently bubbling as it works. Remember, gently bubbling in the suction control will indicate that the suction is working. So the water level controls the negative pressure. As water evaporates, the negative pressure can also change, so it is important to check the water frequently to avoid such. The second type of a chest tube is the dry suction. In the dry suction, there is no water column as in the wet suction, right? So there's no water column to control suction, but the dry one uses a suction monitor bellow that will balance the wall suction, and you can actually adjust water suction pressure using the rotary suction dial on the side of the system. So bottom line is you don't have water column, so no bubbling like the wet suction. No water for evaporation. This is not a concern here. So the dry suction, you're going to find that it is a more silent system because there is no bubbling, okay? And if there is a bubbling could indicate there is a leakage. It's self-regulating, and negative pressure is controlled by vents and controlled system. Controlled leaching system can be suction or they can be the gravity. So this one is more quiet compared to the wet, which will be noisy. So you could get a question like, which type of chest tube system does this statement describe? This chest drainage system has no water column to control suction, but uses a suction monitor bellow that balances the wall suction, and you can adjust water suction pressure using the rotary suction dial on the side of the system. It allows for higher suction pressure levels and has no bubbling sounds, and water does not evaporate from it as other systems. Remember, we have said that we have two common types of chest tube system, the dry and the wet. And if you look at the description keenly, you realize that this system described here is the dry suction chest tube. Remember, we have said that it's the one that uses a suction bellow that balances the wall pressure, and you can adjust water suction pressure using the rotary suction dial on the side of the system. So how does the chest tube work? Well, normally tubes will be inserted in the pleural space. Then the fluid is suctioned into a suction chamber. Then we have to keep the nurse responsibilities that we need to keep this suction chamber below the level of the heart to help with the drainage. Remember, most people, you're going to be interacting with questions and someone will be asking you what are the interventions for a client with a chest tube for pneumothorax. Number one is to make sure that you keep the drainage below the chest level to enable the gravity, at least to enable the drainage, right? And you can be able to observe it from our client here on our right. So a chest tube normally has three chambers. We have the suction chamber, control chamber. Then we have the water seal chamber, and then lastly we have the collection chamber to measure the output. Starting with the suction control chamber, this one shows gentle, steady, or continuous bubbling, especially in patients suffering from conditions like pneumothorax. It should not be vigorous nor violent, because that will mean that the suction is too high. So your responsibility as a nurse is just to check the color of the drainage and the amount of the drainage. So there's a question here. You are assessing a patient who is on post-op from chest tube insertion. On assessment, you know that there is a 50 cc of seranguinous fluid in the drainage chamber, fluctuation of water in the water seal when the patient breathes in and out, and bubbling in the suction chamber. Which of the following is the most appropriate nursing intervention? Documenting your normal findings, assessing for air leak due to bubbling noted in the suction chamber, notify the physician about the drainage, and milk the tubing to ensure patency of the tubes. When looking at all these options by the nurse, we can go for nurse A. Nurse A actually is doing the right documentation, the right action. He's documenting this one as the normal finding, right? We need to find drainage. We need to find a fluid in the drainage chamber, and it should be less than 100 cc per hour, right? We need to see fluctuations of water in the water seal when the patient breathes in and out. Bubbling in the suction control chamber is also a normal finding. So from the first chamber, now we go to the second one, and the second one is the water seal chamber, and it also has an air leak monitor. This one normally acts as a one-way valve to help drain fluid, air, or blood from the lungs. This chamber normally prevents air from entering the chest cavity, so we need to see a steady rise and fall with breathing. That this is what is commonly referred to as tidling, right? Remember, continuous bubbling is a bad sign because it shows there is an air leak inside the system. The vent, we know normally when you're on the vent, you need to breathe in. When you normally breathe in, water decreases. When you breathe out, water increases. Remember, this will be opposite to chest now, chest tube. If there are no fluctuation, maybe the lung has either re-expanded or there is a kink. So water creates one-way valve that will prevent air or fluid from returning to the patient's chest. As you continue with the procedure, you need to monitor for air leaks through the bubbling, the tidling, that is fluctuations in the fluid level, and the increased negative pressure. So the question is, the registered nurse is providing care to a patient with a chest tube. On assessment of the drainage system, the nurse notes continuous bubbling in the water seal and oscillation. Which one of the following is the correct nursing intervention? Continuous. Reposition the patient because the tubing is kinked. Continue to monitor the drainage system. Increase the suction to the drainage system until the bubbling stops. Check the drainage system for an air leak. So the best nurse here is nurse D. You need to check the drainage system for an air leak because that is an abnormal finding at this stage. What about a patient is receiving a positive pressure mechanical ventilation and has a chest tube? When assessing the water seal chamber, what do you expect to find? The water in the chamber will increase during inspiration and decrease during expiration. There will be continuous bubbling noted in the chamber. The water in the chamber will decrease during inspiration and increase during expiration. The water in the chamber will not move. Of course, nurse D is automatically wrong, but the nurse C is the best nurse because you need to see that the water in the chamber is going to decrease in inspiration and also increase during expiration. So when they breathe out, the water seal is supposed to rise. When you breathe in, decrease, right? Decrease. Remember, this is opposite on a vent, right? On a vent, when a vent, it will be opposite. It will be increasing during inspiration and decreasing during expiration. A patient with a chest tube has no fluctuation of the water in the water seal chamber. What could be the cause of this? This is an expected finding. The lung may have re-expanded or there is a king. The system is broken and needs replacement. There is an air leak or the tubing. NAS B is the best response, where maybe the lung might have re-expanded or there is a king in the system. That's why there are no fluctuation in the water seal. The last chamber is the collection chamber. So we need to see continuous bubbling here. You keep adding water to the prescribed level to prevent evaporation, and you monitor lung sounds to monitor breathing. So we have several aspects of chest tube tube management. Like in assessment and monitoring, you need to monitor the patient. So you assess the respiratory rates, the effort, oxygen saturation, breath sounds, and free regularly. You monitor for pain and provide appropriate analgesia. For chest tube monitoring, you ensure that the tube is properly secured and free of kinks or obstructions. You check the dressing for integrity, bleeding, and signs of infection. And you monitor for subcutaneous emphysema. This is if in that case, the patient could present with palpable cryptus around the insertion site, emphysema. For the drainage system maintenance, you need to observe the water seal chamber. So you check for the tidling, that's the movement with the respirations, and this could indicate proper functioning. Absence may indicate that there is either a blockage or the lung has re-expanded. Continuous bubbling suggests an air leak. Intermittent bubbling is the expected during pneumothorax resolution. You also need to record the amount, color, consistency of the drainage every shift or more frequently as needed. Report excessive drainage, e.g., more than 100 mils per hour or sudden increase. You have to report that. Keep the system below the chest level. This will help prevent backflow of fluid into the pleural space. So a question goes here that a patient is recovering from pneumothorax and has had a chest tube present. Which one of the following is an appropriate finding when assessing the chest tube drainage? Intermittent bubbling may be noted in the water seal chamber. 200 per hour is expected during the recovery. 200, that one is extremely wrong. You need to have at least that, you need to have 100, less than 100 cc per hour, less than. The chest tube is positioned at the patient's level to facilitate drainage. At the patient level, below, right, below. So the intermittent bubbling may be noted in the water seal. That will be a normal finding. In terms of patient care, you need to encourage lung expansion, like promote deep breathing, coughing, and incentive spirometry, assist with repositioning and early ambulation to prevent complications like atelectasis, and provide adequate pain relief that will help facilitate effective breathing and mobility. In terms of troubleshooting the common issues, if there is an air leak, you need to check all the connection for tightness. Also assess the insertion site for displacement. If there is a disconnection of the tubing, you could immerse the end of the chest tube in sterile water to just create a temporal seal and reconnect the drainage system as soon as possible. In case you have accidental removal, you could cover the insertion site immediately with a sterile gauze tapped on 3 sides to prevent tension pneumothorax, then notify the physician immediately. So there's a question here that while helping a patient with a chest tube repositioning in the bed, the chest tube becomes dislodged. What is your immediate nursing responsibility? Stay with the patient and monitor their vital signs while another nurse notifies the physician. Place a sterile gauze over the site and tap it 3 sides and notify the physician. Attempt to reinsert the tube. Keep the site open to air and notify the physician. Well, D will result into tension pneumothorax, right? Yeah. In attempting to reinsert, this is you have to inform the physician who is going to do that. When you just stay with the patient and monitor the vital signs, what are you doing? You not have helped the patient. Instead, you need to place a sterile dressing over the site and tape it on 3 sides and then notify the physician. A patient is about to have their chest tube removed by the physician. As the nurse assisting the removal, which of the following action will you perform? Educate the patient how to take deep breath and inhale rapidly while the tube is being removed. Gather the supplies needed, which could include petroleum, gauze, dressing per physician preference. Help place the patient in semifolars position. Have the patient take deep breath, exhale, and bear down during the removal. Pre-medicate the patient prior to removal as ordered by the physician, and then place the patient in a prone position for removal. Well, at least premedicating the patient before removal, that you could give maybe analgesia just to take care of the pain. Have the patient take breath and so that they exhale and bear down during right, so that you are going to encourage the patient to have the create the Valsalva maneuver that helps to at least remove the tube. Place the patient in semifolars position and gather supplies needed. Those are the correct options. So there's this concept of milking the tube or stripping the tube. This one, it used to be used to primarily ensure that the tubes remain patent. So you're supposed to remove any secretions in the tube and so on and so forth. But lately, some practitioners and some researchers have questioned this practice, and they suggest that it could be a possible source of harm to the patient in that it can increase pressure within the tube. So for that reason, this practice is no longer recommended. So the patient in room XY calls on the call light to tell you something is wrong with this chest tube. When you arrive to the room, you know that the drainage system has fallen on its side and is leaking drainage into the floor from a crack in the system. What is your next priority? Place the patient in supine and clamp the tubing. Notify the physician immediately. You have not done anything, remember. Disconnect the drainage systems and get a new one. Disconnect the tubing from the dressing and insert the tubing 1 inch into a bottle of sterile water and obtain another system. I think that's what you need to do so that you are at least you've been able to take care of the patient, and looking at the long term, you also want to secure a new system, and you have prevented the formation of complications like tension and pneumothorax. So we have emergency situation when a patient is on this chest tube, like tension pneumothorax. Somebody may have tension pneumothorax, and what are the signs that will make you suspect that your patient is having tension pneumothorax? Maybe having sudden respiratory distress, having tracheal deviation, hypotension, absent breath sounds. So what do you need to do in this case? You have to notify the physician immediately for emergency decompression. A patient could also present with massive bleeding. Signs could be large volumes of bright red drainage. So you need to notify the physicians promptly and also prepare for possible intervention. Then there's this concept of removal. Of course, what is the criteria for removing a chest tube? You look at the drainage. If there's minimal drainage, like less than 100 mils in 24 hours, that one you can remove. If there is no air leak for about 24 to 48 hours, and if lung re-expansion has occurred, and this can be confirmed by the chest X-ray. So what is the procedure? You have to administer the analgesic as the pre-med medication just to take care of the pain in the patient. Instruct the patient to perform the Valsalva maneuver during the removal to aid the easy removal of the tube. Then apply an occlusive dressing and a monitor just to prevent the complications like pneumothorax. Also do a chest x-ray just to assess and be sure of lung expansion. What are some of the nurse responsibilities that you're supposed to facilitate in a patient with a chest tube? You educate the patient on the purpose of the chest tube and the signs of complication. Ensure regularly document assessment, drainage, output, and intervention. You ensure emergency equipments around, like the clamps, the sterile water, the dressing supplies is readily available. They ensure effective chest tube management will involve vigilant monitoring, patient educations, prompt response to complication to optimize the outcomes. So there's a question here for which of the for a client who has a chest tube connected to a closed water seal drainage system, the nurse should include which action? Measuring and documenting the drainage in the collection chamber, maintaining continuous bubbling in the water seal, keeping the collection at the chest level, stripping the chest tube every hour. So you measuring and documenting the drainage is in the chamber is the most appropriate, right? Remember the bubbling should be intermittent, right? And you keep the collection chamber below the chest level, right? So the nurse should regularly measure and document the amount of chest drainage to detect abnormal drainage patterns such may occur with hemorrhage, that is if excessive, or blockage if decreased. Continuous bubbling in the water seal, this one will indicate that there is a leak in the closed chest drainage system which must be corrected. The nurse should keep the collection chamber below the chest level to allow fluids to drain in it. The nurse shouldn't strip chest tubes because doing so may traumatize the tissues and dislodge the tube. We have a client who is recovering from a chest trauma, is to be discharged home with a chest tube drainage system. The nurse should instruct the client to call the physician for which of the following sign? Respiratory rate greater than 16, chest continuous bubbling in the water seal, fluid in the chest tube, fluctuations of fluid in the water seal, right? Okay, the nurse should call for the continuous bubbling in the water seal chamber. Remember, continuous bubbling in the water seal chamber will indicate that there is a leak in the system, and the client needs to be instructed to notify the physician if continuous bubbling occurs. As for the respiratory rate, a respiratory rate of more than 16 breaths per minute may not be naturally unusual. And it does not necessarily mean that the client should notify the physician. Remember, the normal respiratory record for an adult is 12 to 20 breaths per minute, of which 16 is still within the normal range. Fluid in the chest is expected as fluctuation of the fluid in the water seal drainage. Lastly, we have a question here. When assessing a client with a chest tube inserted for hemothorax, the nurse should expect which of the following findings? Fluid drainage into the first chamber of the drainage system, a dry dressing at the chest wall insertion site, tidling in the water seal during respiration, use of accessory muscle during respiration, subcutaneous emphysema at the chest wall. Correct. We have the drainage, a dry dressing at the chest wall, and the tidling, right? And tidling during respiration. Remember, fluctuation in the water seal during respiration and a dry dressing at the insertion site are the only expected findings. Subcutaneous emphysema will indicate air in the tissues and will not be a normal finding. Use of accessory muscles indicates respiratory distress and should also be further assessed. So, okay, ladies and gentlemen, thank you so much for creating time for this presentation on chest tube. Please find time, go through it, and attempt the free quiz in the description section. If you find this content useful, you could share with your classmates, and let's share feedback to see how we can progress. Otherwise, thank you so much. See you again in the next video.